Okay, so I'm adding on a couple of videos to the pre-existing presentation. The first topic I'd like to talk to you about is TOLAC, which is trial of labor after cesarean, and VBAC, which is vaginal birth after cesarean. These aren't pathological conditions. They are just a little riskier than birth in a woman who doesn't have any previous uterine scarring. The major risk is uterine rupture. So if you have an incision, you have a weakened area where contractions and the descent of the fetus could put stress and actually rupture that uterus. Absolutely, in no circumstance should you attempt VBAC with someone who has had a previous, what they call classical or vertical uterine incision, one that goes up and down. If the skin incision is vertical, that doesn't indicate what the uterine incision was, but you should have an operative report that gives you that information. Short intervals between pregnancies, less than 6 months from the end of the last pregnancy and the beginning of this pregnancy. Be careful with big babies. 40 weeks gestation, you have hyperdistension of the uterus. More than one cesarean section is a contraindication for VBAC. And be careful with induction methods. So we can induce with oxytocin, but that's really the extent of what we can do. You cannot use Cervidil or misoprostol in a VBAC or a TOLAC because it softens the entire lower uterine segment, including the area where that incision was. You have to assess your contractions with palpation frequently and avoid tachysystole. Those would be the considerations for VBAC and TOLAC. Yep, there's my reference slides. Uterine rupture, another adrenaline rush in L&D. This is a catastrophic emergency where you actually have the uterine rupture. What it is, it's a tear in the uterine wall, just like you see in the picture here. It is more common with previous uterine surgery, especially vertical incision or any other type of uterine surgery. Tachysystole, if we're hyperstimulating the uterus to contract, we're creating a situation where the uterus is more likely to rupture. Over-distended uterus, and this can be because of large fetuses or excessive amniotic fluid. Be very, very careful if you are doing an amnio infusion. Because you're instilling fluid, you need to make sure that that fluid is coming back out. You use an intrauterine pressure catheter with an amnio infusion. So you need to look at the resting tone and palpate a lot. Make sure that that uterus gets soft in between contractions. Make sure that there's adequate resting time. And the last cause of uterine rupture could be abdominal trauma. So what it looks like, a uterine rupture will feel like ripping pain in the lower abdomen. It sometimes refers to the shoulders because of the nerve pathways. And you'll have a sudden development, usually of fetal bradycardia. You might even see a sinusoidal pattern because the baby is now losing oxygen. Maternal hypotension and tachycardia. What you will palpate initially is weaker contractions and finally no contractions. You might actually palpate fetal parts in the abdomen, depending on the size and location of that rupture. When you do a cervical exam, there will be loss of fetal station because now the baby's not pressing down with the contractions of the uterus because the uterus can't do that anymore. So you might have had a baby who was like a +1 station. They were at the 1 centimeter past the level of the spines, and now you can't find the baby's head. Tenderness to palpation, extreme tenderness. For example, you go to replace the toco because you're not seeing contractions, right? Because your uterus, the integrity of the uterus is gone. So you go to move the toco, and every place you move it, even with light touch, that woman is like in excruciating pain. And as I said, fetal parts could be palpable. You might be able to palpate small parts as if there was no uterus. So what you would do about that is, this is a crash C-section, probably under general because you don't have time to sit up for spinal or, an epidural. If there's an epidural and it's working adequately, you might use that, but typically it's not going to be enough anesthesia. They probably have to put mom to sleep and intubate her. Possible hysterectomy if the uterus cannot be repaired, to prevent massive hemorrhage. And you'll do all the things you do in any bleeding emergency: 2 large bore IVs, volume replacement with crystalloid fluids like normal saline or lactated ringers, and then you would be ready to initiate the massive transfusion protocol. And that's a topic for a separate presentation. Oh, that's the last slide. Okay.